welcome to the Funnel Effect.
Thank you. It's a real pleasure to be here to discuss this one.
Today we are taking a deep dive into a topic that combines high-stakes emergency medicine with just the sheer brute force of geography.
It really does read like a logistical thriller, honestly.
Yeah, set in the frozen north. So before we get into the drama of the ice and the ambulances, I want to make sure we give full credit to the team behind this massive undertaking.
Right. The source material is crucial here.
Exactly. So I'm going to read the full list of authors and the source publication details to establish the credibility of what we're looking at. The authors are Ellen Bermer, Harold Arneson, Michael Abdelnour, Errol Mengschau, Pavel Hoffman, and Sigrun Halvorsen.
A phenomenal group.
They represent the Department of Cardiology at Ullevål University Hospital in Oslo, Norway. And this work was published in the Scandinavian Cardiovascular Journal.
That was back in 2007, I believe.
Correct, volume 41. And the title of the paper is The NORwegian Study on District Treatment of ST-Elevation Myocardial Infarction,
Which, thankfully, is known in the cardiology world as the NORDISTEMI study.
I'm very glad they gave us an acronym.
Oh, absolutely. It's a powerhouse team from Ullevål. I mean, they are essentially the final destination for heart patients in that entire region.
So they really have a unique vantage point on everything we are about to unpack today.
They see the end result of all these logistical chains.
So let's set the scene for you listening at home. I want to transport you to rural Norway.
And we aren't talking about the bustling streets of downtown Oslo here.
No, not at all. We are talking about the southeastern part of the country.
Right. Think vast open landscapes.
Exactly. Large, sparsely populated areas. I mean, it is stunningly beautiful. You've got fjords, mountains, endless forests.
But from a medical logistics standpoint, it is a complete nightmare.
It really is. You have narrow roads that wind around the base of mountains. You have weather that, changes in a heartbeat.
And you have distance. Distance is the main antagonist in the story.
We are talking about patients living anywhere from 100 to 400 kilometers away from a specialist heart center.
Which is a massive gap when you are dealing with cardiac emergencies.
So imagine you are in a cabin in one of these remote valleys. It's winter, it's dark, and suddenly you feel that crushing weight on your chest.
You're having a STEMI.
Let's pause there and clarify what that means for the listener.
Good idea. A STEMI is an ST-elevation myocardial infarction.
So this isn't just generic chest pain.
No, this is a major heart attack where a coronary artery, which is one of the main fuel lines to the heart muscle, is completely 100% blocked.
The pipe is shut.
The pipe is shut. And the moment that blood flow stops, the heart muscle downstream begins to starve.
It runs out of oxygen.
Exactly. The cells start dying. And this brings us to the most fundamental rule in cardiology, which is time is muscle.
Time is muscle. I love that phrase because It is so visceral. It's not abstract at all.
No, it's very literal. Every single minute you wait, you are losing grams of heart tissue that you can never, ever get back.
And the gold standard treatment for this, the absolute best thing we can do for a STEMI, is called PCI.
Right. Percutaneous coronary intervention.
Or angioplasty, as a lot of people might know it.
Yes. The process is you rush the patient to a catheterization lab. You thread a wire up into the heart, you inflate a balloon to smash the clot open, and then you place a metal stent to keep the artery wide open.
It is entirely mechanical, it is immediate, and it works wonders.
It's the best tool we have.
But here's the problem for our patients in Norway. In this entire vast region of the southeast, there is only one center that can do this round the clock.
And that is Ullevål University Hospital in Oslo.
And that bottleneck creates what we call the 90-minute rule problem.
Right. The European guidelines, which this study is strictly based on, say that if you can get a patient to a PCI center within 90 minutes of first medical contact, you absolutely should do it.
That is the magic window.
That is the window to save the most muscle.
But for the people in this study, the delay is almost always longer. I mean, if you are 400 kilometers away on a winding, icy road, you are not getting there in 90 minutes.
You might not get there in 4 hours.
Exactly. So for these patients, the gold standard of primary PCI is just physically impossible.
You cannot just put them in an ambulance and drive for 5 hours while their heart slowly dies.
Right. You have to do something else. You need an alternative.
Which brings us to the core of the NORDISTEMI mission.
Let's unpack that. If you can't get to the plumber to fix the pipe physically, what is the standard of care out there in the wild?
The standard solution, and what has been used out there for decades, is thrombolysis.
Chemical warfare against the clot.
Essentially, yes. You inject a very potent drug into the bloodstream that chemically dissolves the blood clot.
It goes right after the structure of it.
It attacks the fibrin mesh that literally holds the clot together.
And the Norwegian healthcare system is incredibly efficient at this, isn't it? The study makes a real point of highlighting their infrastructure.
It is world-class. They do not wait for you to arrive at a local hospital. They have a system where paramedics in ambulances are highly trained to administer these drugs pre-hospitally.
All over the field?
Yes. Or they dispatch an air ambulance, a helicopter, with a physician on board to land near you and start the IV treatment immediately.
So they are starting the clot-busting process while you are still in your driveway or,
Yeah.
hovering over a fjord somewhere.
Exactly. And that buys time. It reopens the vessel and restores the blood flow.
But there's a catch.
There is a huge catch, and it's what drives this entire research project. Thrombolysis is simply not perfect.
How often does it actually work the way we want it to?
It achieves what we call TMI3 flow, which is normal, brisk, healthy blood flow in only about 60% of patients.
Wow, so 40% of the time, even after you give these heavy-duty drugs, the artery is still partially blocked.
Correct. Or the flow is just very sluggish. Or, even worse, the clot dissolves but then quickly reforms because the underlying ruptured plaque is still there, acting as a trigger.
So pre-hospital thrombolysis is a great bridge, but it is definitely not a guaranteed cure.
It is a stopgap, which leads to the core research question of NORDISTEMI.
Right, because they aren't asking if they should give the drugs. They have to give the drugs because of the sheer distance.
The drugs are mandatory. The real question is what happens next?
Once you have given that potent drug in the back of an ambulance 200 kilometers from Oslo, what do you do with that patient?
And this is exactly where the study splits the patients into two distinct groups. Strategy A is the early invasive group.
This is the aggressive strategy.
Highly aggressive. The protocol here is you give the drugs, and then immediately, regardless of how the patient says they feel, you put them in the ambulance or the helicopter, and you transfer them that 155-plus kilometers straight to Oslo.
So you don't even wait to see if the drugs worked perfectly?
No. You take them straight to the angiogram lab to check the work visually and likely put in a stent.
You assume the chemical job isn't done until you verify it mechanically.
Precisely. You do not wait for failure. You anticipate the need for follow-up.
Okay, and then strategy B is the conservative group.
This is the ischemia-guided approach. You give the drugs, you take them to the nearest local community hospital, and you wait.
You just monitor them.
Right. If the pain goes away and the EKG looks better, you keep them there in the local community.
You only transfer them to Oslo if the drugs obviously fail.
Yes, which we call rescue PCI, or you transfer them if they show signs of trouble later on, like recurrent ischemia.
So the overarching dilemma of this deep dive is this. Do we over-treat everyone by rushing them to Oslo just in case? Or do we try to save resources and spare patients the long, dangerous trip by keeping them local if they seem stable?
That is the exact tension. And you might ask, well, why not just move everyone? Better safe than sorry, right?
Right. What's the downside?
You have to remember, long-distance transport of a heart attack patient has serious risks.
What kind of risks are we talking about?
You are putting a person who just had a massive cardiac event into a vibrating, bouncing vehicle for 4 or 5 hours.
That sounds rough, even if you're healthy.
Exactly. They can develop arrhythmias, irregular heartbeats that can be instantly fatal. They can have severe bleeding complications from all the drugs bouncing around in their system.
And I imagine it is incredibly expensive.
Helicopters and specialized cardiac ambulances cost an absolute fortune to run.
But on the flip side, if you stay put at that small local hospital, you might be sitting on a ticking time bomb.
That is the fear. The patient might say they feel fine, but that artery could still be 90% narrow, just waiting to close up completely again.
And if you miss that window, you could have a reinfarction.
A second heart attack 2 days later while they are recovering in a hospital that can't fix it.
So NORDISTEMI is really testing the safety and efficacy of that long transfer versus the risk of staying put.
Let's look at who they actually tested this on, the patient profile.
Yes, who are the subject?
They were looking for a very specific profile, men and women aged 18 to 75, and they had to have chest pain for less than 6 hours.
Why that specific cutoff?
Because thrombolysis works best when the clot is fresh. If it's been there too long, it hardens, and the drugs can't dissolve it as effectively.
And they had to have that specific EKG signature, the ST elevation.
Yes, that confirms it is a full blockage.
But the most important inclusion criterion was the geography.
The expected transport time to the PCI center in Oslo had to be greater than 90 minutes.
If you lived closer, you were completely excluded.
Because if you live closer, you just go straight to the cath lab. There's no dilemma.
They also excluded people in cardiogenic shock. Why is that?
Cardiogenic shock means the heart muscle is failing so badly as a pump that the patient's blood pressure is crashing and their organs are shutting down.
Oh, wow. So they are critical.
Too sick to be randomized in a trial like this? Those patients need to be flown to Oslo immediately, no questions asked, often for mechanical support.
They also excluded pregnant women and people with severe kidney failure.
Standard safety exclusions for these heavy drug trials.
Let's talk about the medicine itself, the cocktail. Because before anyone was randomized to go or stay, everyone got the exact same drug regimen.
And it is quite a heavy mix. It's an aggressive pharmacological regimen. The NORDISTEMI authors were not messing around here.
They threw the kitchen sink at the clot.
They used a combination of 4 specific drugs to try and stabilize these patients for the long haul.
Walk us through the ingredients of this cocktail.
First, you have tenecteplase. This is the primary thrombolytic, the main clot buster.
What makes it special?
It's a genetically modified form of tissue plasminogen activator. It is fibrin-specific, which means it acts like a guided missile to target the clot itself, rather than just dissolving clotting factors everywhere in your body.
Yeah, it's easy to give, right?
Very. It is given as a single weight-adjusted bolus, one quick push from a syringe.
Which is fantastic for paramedics working in the back of a moving ambulance.
Exactly. No hanging 5E bags and calculating drip rates for hours.
Second ingredient.
Aspirin. A solid 300 milligram loading dose.
Just to make the platelets slippery so they don't clump together.
Right. Then we have enoxaparin.
What does that do?
This is a low molecular weight heparin. It's a powerful anticoagulant. They give an IV bolus so it starts working instantly in the blood, and then they follow it up with a subcutaneous injection, a shot under the skin, so it keeps releasing and working over time.
And the fourth drug in the cocktail.
Clopidogrel. Another 300 milligram loading dose.
Now, clopidogrel is another antiplatelet agent, right? But it works on a different receptor than aspirin.
Yes. And this is a really key insight into the study's design. The inclusion of clopidogrel here is massive.
Why do they need 2 different antiplatelet drugs? Isn't the aspirin enough?
You see, when you dissolve a clot aggressively with tenecteplase, you release a massive amount of thrombin into the local area.
The very stuff that makes clots.
Yes. So paradoxically, the act of busting the clot creates a highly prothrombotic environment. The body essentially panics and tries to rebuild the clot immediately.
So you are melting the dam, but the local beavers are working overtime to rebuild it instantly.
That is a perfect analogy. The clopidogrel acts as a secondary inhibitor to stop those beavers.
To keep the debris from clumping back up.
The NORDISTEMI team was directly referencing the Clarity-TIMI 28 findings here, which had just shown that adding clopidogrel significantly improved the odds the artery would actually stay open after you busted the initial clot.
So this was a very modern, aggressive touch compared to older previous studies.
It was cutting edge at the time.
So they were basically marinating the patient in blood thinners to keep those pipes open during the incredibly long drive.
Marinating is a vivid way to put it, but medically, yes, that's exactly what they're doing. They're doing everything biochemically possible to prevent reocclusion.
Okay, so the patient gets the cocktail, then they are randomized. If they draw the card for the invasive group, they arrive at Ullevål. What happens behind those doors?
Immediate angiography. They thread the catheter up, inject dye to visualize the coronary arteries on an X-ray screen.
Looking for the blockage.
Looking for the culprit artery, the specific one that caused the heart attack. If they find it is still more than 50% narrowed, they put a stent in it immediately.
And what if they draw the card for the conservative group?
They stay at their local community hospital, but the protocol has a built-in safety valve, which is critical.
What triggers the safety valve?
If the drugs clearly don't work. Meaning, if the patient still has severe chest pain and their EKG hasn't improved by at least 50% after 60 minutes.
That's the rescue indication.
Exactly. If the drugs fail, the local doctors bail out on the conservative strategy and put them in a helicopter to Oslo anyway.
So conservative doesn't mean you just ignore them.
Not at all. It means you watch and wait with a very close eye.
Let's shift gears slightly and talk about the landscape of cardiology at the time. Why was this specific study necessary when they launched it?
Context really is everything in clinical trials. Prior to NORDISTEMI, we had several major studies, but none of them quite fit the unique Norwegian reality.
The authors cite the DENAMI study pretty prominently.
They do. DENAMI was a landmark trial. It showed clearly that transferring patients for primary PCI was better than just keeping them local and giving them thrombolysis.
But there is a catch with DENAMI.
A huge catch. The median transfer distance in the DENAMI trial was only 50 kilometers.
50 kilometers is nothing. That's a morning commute.
Mm-hmm.
It's absolutely nothing compared to the 400 kilometers we are talking about in rural Norway.
Exactly. You simply cannot extrapolate safety data from a short 30-minute trip to a cross-country 5-hour haul. The physiological risks to the patient increase with every single kilometer.
What about the other studies they mentioned? Gracie 1 and Capital NI.
Those trials also showed significant benefits to early invasive strategies. They showed fewer repeat heart attacks, less ongoing ischemia.
But again, the logistics were different.
Very different. The patients in those trials were often already sitting inside hospitals when they were randomized, or they had very, very short transfer times.
So NORDISTEMI is totally unique because it is actively testing the extreme limits of medical logistics.
It's testing the tyranny of distance.
It is asking a really tough question. Does the long-term benefit of getting that metal stent actually survive a brutal 4-hour ambulance ride?
Or does the delay and the physical stress of the transport negate the benefit entirely?
Now, there's a major plot twist in the timeline of this research.
A very stressful one for the investigators, yes.
Right. While NORDISTEMI is running, actively enrolling these rural patients, another massive global study drops its results. The ASCENT-4 PCI study.
And the results were disturbing, to say the least.
Disturbing is definitely the word. ASCENT-4 was looking at something called facilitated PCI.
Which basically means intentionally giving full-dose thrombolysis before doing a planned PCI.
Which sounds exactly like the NORDISTEMI invasive arm.
On the surface, it sounds identical.
And what did the ASCENT-4 trial find?
They found that the patients who got the clot-busting drugs right before their stent actually did worse.
Worse than who?
Worse than patients who just got primary PCI alone without the prior drugs. The facilitated group had higher mortality, more strokes, and way more complications.
Wait, so giving the clotbuster before the stent actually killed more people in that trial?
It did. It caused a massive controversy. The whole medical community suddenly pumped the brakes and said, stop mixing these strategies, it's dangerous.
That must have terrified the NORDISTEMI researchers. Why didn't they stop their study immediately?
They had to look much deeper at the data to justify continuing. First, a sub-analysis of ASCENT-4 showed a fascinating detail.
What was it?
The patients in ASCENT-4 who were treated in ambulances pre-hospitally, rather than waiting until they got to a clinic, actually did better.
So the very early timing of the drug administration mattered.
It mattered a lot, but the most important ethical reason they didn't stop is that the NORDISTEMI patients literally have no other choice.
Right. In ASCENT-4, maybe those patients lived in cities and could have just chosen primary PCI without the delay.
Exactly. In rural Norway, primary PCI without delay is physically impossible due to that 4-hour drive.
You cannot just leave a patient completely untreated in an ambulance for 4 hours.
The thrombolysis is mandatory to keep them alive for the trip. So the experimental variable for NORDISTEMI isn't drugs versus no drugs.
It is transfer versus no transfer.
That crucial distinction is what allowed them to ethically continue enrolling patients.
Also, the cocktail was different between the two trials, right?
Yes, very important point. ASCENT-4 did not use the aggressive antithrombotic mix with clopidogrel and enoxaparin in the exact same optimized way.
So the beavers were still building dams in ASCENT-4.
You could say that. The NORDISTEMI team firmly believed their specific cocktail was safer and would prevent those fatal thrombotic complications seen in ASCENT-4.
It is amazing how much nuance there is in trial design. It's not just drug A versus drug B. It is about timing, it's about distance, and the very specific combination of the agents.
Medicine is highly contextual.
So let's look at the preliminary results. The paper covers the status of the trial as of April 2006.
They had enrolled 109 patients at that point, out of a total goal of 266.
And this is where the funnel effect really starts to show up in the hard data. Let's talk about the distances first.
The logistics numbers are mind-blowing.
The median transport distance for these patients was 155 kilometers.
Median, which means exactly half of the patients had to travel even farther than that.
And the maximum distance recorded, 396 kilometers.
Just try to visualize what that actually means for a human being.
You are strapped to a narrow gurney, you are in immense chest pain, and you are sliding around icy mountain corners in the dark for nearly 400 kilometers.
And the time data reflects that brutal reality. The median time from symptom onset to arriving at the catheterization lab in Oslo was 285 minutes.
That is nearly 5 hours.
5 hours.
Mm.
If they had not received that pre-hospital thrombolysis, that heart muscle would be largely dead, irreversibly necrotic.
That data point alone confirms why the pre-hospital drug treatment is non-negotiable in this environment.
Absolutely.
Speaking of the pre-hospital care, how successful were the paramedics at actually delivering the cocktail?
Incredible success rates. 52% of all the patients received their thrombolysis before reaching any hospital whatsoever.
They got it right there in the ambulance or from the flight crew?
Yes. The median time to needle, which is the time from symptom onset to the actual drug injection, was 134 minutes.
So while it takes 5 hours to physically get to the stent in Oslo, they are getting the life-saving drugs in just over 2 hours.
That 3-hour gap is the absolute life-saving window that these drugs provide.
But safety is always the big worry with a long transport, especially after giving powerful blood thinners. Did anyone die on the road?
They report only one death during transport in this preliminary batch of data. Generally, the transport was considered very safe.
What about the overall mortality?
The 30-day mortality for the whole group was very low, sitting at only 2.8%.
That sounds remarkably low for people having major heart attacks in the middle of nowhere.
It is an excellent outcome. It speaks volumes to the quality of the pre-hospital care and the pure efficacy of that 4-drug cocktail.
Now, here is the statistic from the results that I think is the most telling. It's the real twist in the narrative.
Ah, yes, the crossover data.
Right. We talked about the conservative group, the people who were randomized to just stay at the local hospital and be monitored. Did they actually stay there?
This is the crossover problem. In the conservative group, a full 30% required immediate rescue PCI because the initial drugs just didn't work.
Okay, so nearly a third of the patients failed the drug test right out of the gate and had to be flown out.
Right. And then, on top of that, another 25% were transferred later on during their hospital stay because they developed fresh ischemia.
The chest pain came back.
Yes, or they had stress-induced EKG changes.
So, do the math for me there.
That means over 55% of the conservative patients ended up being transferred to Oslo anyway.
More than half. That fundamentally undermines the entire concept of staying local, doesn't it?
It certainly challenges it.
Because if over half your patients end up in the ambulance regardless of your plan, why not just send them all right away while they are stable?
That is exactly the hypothesis this preliminary data starts to support. If the geographic funnel eventually pulls everyone to Oslo anyway, maybe we should just grease the slide.
Send them immediately rather than waiting around for them to fail locally.
Exactly, because it suggests that conservative treatment often just becomes delayed invasive treatment.
And in vascular medicine, delay is rarely, if ever, a good thing.
Time is muscle. Delay means dead tissue.
Let's talk about how they are ultimately measuring success at the end of this trial. What are the formal endpoints?
The primary endpoint is what we call a composite. They look at the rate of 4 major things occurring at the 12-month mark.
What are the big 4?
Death, reinfarction, which is having another heart attack, stroke, or new myocardial ischemia.
Why lump all those different things together into one endpoint?
Because, thankfully, outright death from a heart attack is relatively rare in modern cardiology.
So you need more events to measure.
Right. To get statistically significant results without needing to enroll 10,000 patients, you combine these major adverse cardiac events into one metric.
They are also checking closely for bleeding complications, I imagine.
Yes, absolutely. That is a crucial secondary endpoint. When you mix tenecteplase plus clopidogrel plus aspirin plus enoxaparin, that is a potent recipe for major bleeding.
What kind of bleeds are they worried about?
They are tracking major bleeds, the kind that require a blood transfusion or emergency surgery, and specifically intracranial hemorrhage.
Bleeding inside the brain.
Yes. That is the single most feared complication of any thrombolytic therapy. A brain bleed is often fatal or severely disabling.
There's also some high-tech imaging involved in their endpoints. They mention SPECSECT with technetium 99-meter tetraphosmin.
Yes, quite a mouthful. That is a specialized nuclear medicine scan.
How does that work?
They perform this scan at the 3-month mark. Basically, they inject a radioactive tracer into the patient's blood that specifically binds to living, healthy heart muscle.
So it lights up the good tissue.
Precisely. It allows the researchers to see the exact size of the infarct, the dark area of dead scar tissue where the tracer didn't bind.
So it turns a subjective, I feel better, into hard, undeniable data. You can literally say, this strategy saved 12 extra grams of muscle.
Exactly. It is a highly objective way to see if the early invasive strategy actually preserved more heart function over the long term than the conservative one.
Now, we have to talk about the money.
We always do.
Because healthcare isn't just about biology. It is heavily about economics, especially in a nationalized, socialized system like Norway's.
This health economics angle is a major differentiator of the NORDISTEMI study compared to others.
They aren't just counting heartbeats. They are counting kroners.
Right. The assumption going in is that the invasive strategy is vastly more expensive.
I mean, helicopters are not cheap to operate.
Not at all. The upfront cost of an air ambulance transfer and an emergency angioplasty team is staggering.
But there is a long-term calculation here.
A very important one, because managing chronic heart failure is also incredibly expensive.
How so? Walk us through those costs.
If a patient survives their heart attack but is left with a very weak, damaged heart, they consume massive resources.
They need medications for life.
Yes. They might need an expensive surgically implanted defibrillator. They might need frequent rehospitalizations every time they get fluid overload in their lungs.
They might end up in a nursing home prematurely.
Or they might be on government sick leave or disability for years, which costs the state economy heavily.
So the math is, if spending $10,000 today on a helicopter prevents a patient from needing 20 years of expensive disability payments, the helicopter is actually a bargain.
That is exactly the calculation they are trying to prove. They are tracking the total cost per patient at 12 months.
Everything from the initial hospital stay to the GP visits.
Even the use of local physiotherapists and district home nurses. They want to comprehensively know if the expensive invasive strategy is genuinely the cheaper one for society in the long run.
And beyond just the financial money, there's the human cost, the overall quality of life.
Yes, and I'm so glad they included this. They are using two specific questionnaires, the new 15D and the SF-36.
What do those measure?
They ask the patient real-world questions. Can you walk up a flight of stairs without stopping? Are you experiencing depression? Can you still do your job? Can you carry your own groceries?
I love that they track that. It's so easy in these deep dives to get lost in TMI blood flow rates and ST resolution percentages and forget that the ultimate goal is just a happy, functional human being.
Absolutely. Survival is just the floor. Restoring quality of life is the ceiling.
So let's synthesize all of this.
Yeah.
We have looked at the preliminary setup. We see the geographical dilemma. What does this all mean for the bigger picture of cardiology going forward?
It brings us right back to the grand debate of overtreating versus undertreating in remote medicine. It really tests the viability of the drip and ship model.
Drip and ship. I like that phrasing. Drip the drugs into the arm, ship the patient to the city.
The NORDISTEMI study is fundamentally testing whether drip and ship should be the universal default protocol for rural medicine everywhere.
Because that preliminary data showing the massive crossover 55% of conservative patients needing to move anyway strongly suggests that waiting is just wasting precious time.
It seems like the funnel is an inevitable force of gravity. The disease is simply too severe to be reliably managed in a small community hospital setting.
And this study also really highlights the critical role of technology bridging that gap. We briefly mentioned telemedicine earlier.
Yes, the telemetry is the invisible hero here.
Tell us a bit more about how that works in this context.
The local community hospitals and even the paramedics in the ambulances use mobile telemetry systems. They are beaming live EKG data securely over cellular networks directly to the senior cardiology experts sitting in Oslo.
So the expert is looking at the heart rhythm at the exact same time the paramedic is.
Yes, they get real-time second opinions. It validates that entire network concept. You really cannot have a safe rural strategy without a robust communication backbone.
The specialist miles away needs to see what the responder on the ground is seeing. And while this study is set in Norway, the lessons aren't just about Norway, are they?
Not at all. Think about the listeners right now. Maybe you are sitting in the Midwest United States.
Or maybe you are driving through the Australian outback.
Or living in northern Canada.
Or really just anywhere that is far from a major city center.
There are millions of people globally living inside this funnel effect where specialist emergency care is hundreds of miles away.
If NORDISTEMI proves that immediate transfer is safe and effective, despite the long distance, it completely changes the standard operating protocols for all those remote places worldwide.
It also provides massive validation for the role of paramedics.
That's a great point.
It says to the medical establishment, yes, you can entirely trust a trained paramedic to correctly administer a complex, dangerous cocktail of 4 different drugs in the middle of a snowstorm, and it will save lives.
That is a huge vote of confidence for pre-hospital emergency providers.
It empowers them to do more.
And it directly challenges that lingering fear from the ASCENT-4 study we talked about.
Right. It says if the distance to the hospital is long enough, the old rules simply change.
Context is king in medicine. You cannot blindly apply downtown New York City treatment guidelines to an icy mountain pass in rural Norway.
NORDISTEMI is literally writing the new rule book for that mountain pass.
I want to circle back to one small detail you mentioned earlier because it really stuck with me. The clopidogrel.
Ah, yes. The second antiplatelet pill.
It seems like such a tiny thing, just one extra pill in the mix. But do you think that might be the actual pivot point of this whole trial safety?
I firmly believe it's the shield that makes it all possible. The powerful thrombolytic drug breaks the wall down, but the clopidogrel keeps the rubble from piling back up into a new blockage.
Without it, that 5-hour bouncing ambulance ride is a massive gamble with the patient's life.
But with it, it becomes a carefully managed risk. That tiny pharmacological nuance is very likely why their early safety numbers, like that 2.8% mortality, are so much better than the disastrous results in ASCENT-4.
It is truly amazing how much intense thought goes into every single milligram of the protocol.
It absolutely has to. When you are fighting against nature and time like this, you need every single biochemical advantage you can possibly get.
So we have looked at the mission, the drugs, the harsh geography, and the deep economics.
We have covered a lot of ground.
The study was still ongoing when this specific paper was written, but the overall direction seems incredibly clear from the preliminary data.
The conservative approach might ultimately just be a bit of a mirage if everyone ends up needing the city specialist anyway.
It strongly suggests that conservative treatment is just a delay tactic.
And in our specific field of treating heart attacks, we try to eliminate delay wherever we find it.
As we wrap up this deep dive today, I am left thinking mostly about the patients themselves.
It's important to remember them behind all the statistics.
You know, we talk about N equals 109 in the data, but that is 109 individual people whose lives were violently interrupted by a medical catastrophe.
And who then had to endure a literal marathon journey in the back of a truck just to get help.
It is a profound reminder of the resilience of the human body, but also its intense fragility.
And it is a real testament to the logistical marvel of modern healthcare systems. The fact that they can seamlessly coordinate a helicopter, a massive hub hospital, a tiny local clinic, and a paramedic team in the field just to save one piece of muscle.
It really is. It takes a village and a whole lot of gasoline to save a heart out there.
Indeed it does.
And for you listening, the takeaway isn't just about how things work in Norway.
No, it's much broader.
It's about understanding that the definition of best care completely depends on where you are physically standing. If you are in a major city, get to the cath lab instantly. But if you are in the deep country, those potent chemical drugs are your only lifeline.
And if you are in the country, don't be surprised if they pack you up right after the injection for a very long road trip.
It might just be the absolute best thing for your long-term survival.
It just might be.
This has been a truly fascinating look into the raw logistics of survival.
It's the absolute definition of real-world, high-stakes research.
Before we go, I want to leave you with a thought to mull over. We've talked about the incredible logistics required today to deliver this life-saving cocktail. But looking to the future, as drone delivery networks and remote telemetry become even more advanced,
Oh, that's an interesting thought.
could we eventually see a world where this exact chemical cocktail is drone dropped directly to a bystander or a local clinic in minutes, completely bypassing the need for a helicopter to deliver the initial drugs? The funnel might still pull them to the city eventually, but that critical time to needle could drop from hours to mere minutes anywhere on Earth. Something to think about as technology continues to shrink our geography.
The possibilities for remote medicine are definitely expanding.
Thank you for watching The Funnel Effect.